I'm going to be your moderator today, and we're going to talk through some trends as it relates to both the provider side, and by providers I mean facilities, urgent cares, outpatient surgery centers, along with physicians. We're going to talk a little bit about dynamics with payers, and we're going to talk a little bit about dynamics with patients, or that triumvirate of healthcare. I'd like to begin with having each one of our panelists introduce themselves and just tell us a short little bit about where you work and what you're most passionate about when it comes to healthcare.
Hi there, I'm Roger Moczygemba. So I work at a clinic called Direct Med Clinic. It's a clinic I started about 6 years ago. I trained in family practice in the Navy, and then after that I worked in private practice in my own clinic, and then I worked for groups before. So I've done both those, and in 2004 I helped start a telemedicine company called Teledoc. I was the first president of the Physician Association of that, so that was a wonderful experience to.
Has that organization gone anywhere? I'm sarcastic.
During the pandemic, it was wonderful to look back and see that we laid a foundation that stuck and was safe and very, very useful, and it saved hundreds of lives, or thousands probably, during the pandemic. So it was a good feeling to know that I was part of putting that in place. And then before the pandemic in 2016, I helped start another nationwide telemedicine startup called Dial Care. So I'm an innovator. I love that kind of disruption and finding ways to do things better. And so now I am starting a direct primary care clinic, and it was one of the first in San Antonio. In 2018, I got a Master's of Healthcare Administration degree, so that was fun. So my passion is affordable access to healthcare, and you'll probably see that come through when we start talking about this. So I'm so happy to be here on this panel and share and get to know everybody.
So I thought we'd start out with just sort of a broad topic. And so this was a great time of year to be doing research on healthcare trends, because everybody and their brother talks about, what to look forward to in 2024. And what I notice is it's really different dependent upon whether you're running a facility or you work with physicians or you're a payer, but there were some overlaps. So according to Deloitte, more than half of health system executives expect talent shortages and workforce challenges to impact their organizational strategy in 2024. So to me, that means that a lot of the executives are trying to attract and retain staff, but also trying to reduce clinical and clinician burnout. Dr. Moczygemba, do you have some insight around how it could help providers and how they deliver care to patients?
AI?
Yes. And have you seen it, being implemented in places that surprise you?
I've seen what you're talking about, like a smart room and the charting being created from your discussion with the patient. That's really amazing. Another thing that is not so flashy or cool is docs can maybe you've seen this, just use AI to create some wound care instructions or discharge instructions, or this is what you do for this. So that's really quick and easy. So that's
a great example. Just your talk about disruptors and maybe who we need to pay attention to.
I don't have any specifics that you need to pay attention to, except everybody needs to know about direct primary care and direct care, because that's a groundswell. And in my opinion, the value in healthcare starts in the room between the doctor and the patient. And so primary care is so important. And I think that if anybody does research, they can see that the healthcare systems across the world that are doing the best have robust primary care in place. I would like to mention that it's not really, I love technology, and we all love technology, especially when it works right. But it's not the magic, right? It's really access to a doctor.
Yeah, so
And
talk a
so-
little bit more about that.
Yeah. So when a doctor and a patient have a relationship, then technology is just a tool, just like a scalpel in the hand of a surgeon. So just wanted everybody to know, let's be careful not to focus too much on technology as a solution, but it's just a tool. And it's really access to a doctor, that's the magic. There are some disruptors or innovators out there that are capitalizing on what patients need or what they're lacking. But so much, I feel like the more that we can beef up the doctor-patient relationship and restore that they're not going to have a market to develop their product in, right?
That, primary care really is becoming that, the center of that in terms of managing a patient's care. Can you speak to how you've seen that change, and maybe a little bit about why you decided to do what you do?
In our model, it's a beautiful thing that I can help my patients navigate through that. I can help them find a doctor, a center they're comfortable with, and I help them negotiate a cash price, because that's what we're all about, direct pay. And I've got a wonderful story about that if you want to hear about it. And so it's really an amazing thing. An amazing thing started happening when we started sending people to the hospital. I would call up my hospitalist friend and say, this is what I got. And he's like, I'll get you a bed. And then later on that day, that afternoon, or that night, our patients texting us like, hey, this is great. What strings did you pull? They're treating me great.
Why are they being nice to me?
Yeah. And then we had one patient, the staff, as they were admitting him, like, who do you know to get treated like this? We're just doing my job.
Okay, that's a really interesting
And
point.
they're like, hey, they're doing this test on me and that, and we're like, that's good, but I can't get involved, but everything looks good. So.
Okay. Has anybody in here actually gotten online and tried to research like how much a procedure will cost you at Baptist or a hospital? Has it made sense?
No.
So you hear different things. I tried to coordinate a surgery for my husband one time, and I called Christus, Baptist, Methodist, to research like cash pricing and stuff like that. And you hear different things from different people, and it was a nightmare.
Yeah, I can imagine. Dr. Moczygemba, speak to
I'd
that.
love to talk about a lot of stuff. The cost of healthcare is going up because it's by design, actually, through something called the medical loss ratio, which is part of the Affordable Care Act. The medical loss ratio says that whatever an insurance company collects in premiums, they have to pay back 80 or 85% of that to doctors and hospitals. So if you are an insurance company, how do you make your money? It's on that 15%. So you want the cost, you want healthcare spending to be high. So it's by design. So to get around that, in our model, we just don't play the game, right? So in our clinic, for example, the person pays $89 a month, and they can come in as many times as they want, and it doesn't cost them anything. Okay, and then employers buy these memberships for their employees, and they save tons of money that way.
But do they have insurance?
This
So they
is
have
not
to go-
insurance.
I know, but do they have insurance in case that you say you need to go see my
So
friends
the
over here at
employer-
Baptist?
So some patients will still have insurance.
Okay.
And some employers, like the small ones, they can't afford health insurance, so they buy these memberships, which is affordable access to a doctor. Insurance is something different. Employers larger than 50 are supposed to, they're mandated to have insurance. So in that situation, they need a broker that understands how to pair what we do with insurance models that fit for them, not a one-size-fits-all approach.
Okay.
And I wanted to give an example. We have an employer client that has about 600 employees. In the first quarter that we were working with them, they paid us a fixed cost for their primary care. And they told their employees, look, you go see them, it doesn't cost you anything. Wow, how cool is that? They can text us and it becomes a secure app. So that's healthcare too. And then we also saved them in that first quarter over $13,000 in labs and imaging, because we have discount pricing for that because we're a clinic. And so in addition to that savings, we saved them 2 visits to the emergency department because they had access to us. We saved them 6 urgent care visits and 2 visits to a specialist. So that's an example of fixed cost for primary care, and it's affordable access. I mean, how affordable is nothing for an employee of this company, right?
Dr. Moczygemba, any thoughts about value-based care, good, bad, ugly?
My thought is that it needs to start in the room between the doctor and the patient.
You keep saying that.
Yeah, so I don't think it's going to work really well from the top down. It's got to start from the bottom up.
How do we make that happen?
The year before last, I went to Austin and testified to a special committee on health care, and I told them that we do not need health insurance for primary care. Whoa. I told them that, and I said we don't, because I'm proving that we don't with all of the lives that are members of my clinic. So we don't need insurance for primary care. It's accessible to people and it's affordable. So it's kind of like we all have insurance for our cars and we need that, but we don't use it to change the wiper blades, right? So that's a similar analogy to value-based care, primary care, direct primary care.
Never difficult for folks to really kind of understand and see it. It changes quite often.
But still, we're savvy consumers. Dr. Moczygemba, what do you think?
Yeah, no, a couple things. One, if you want to hear a great story about this very point, Google Jay Kempton at the annual meeting last year of the Free Market Medical Association. He gave a phenomenal talk about how he was trying to get a procedure done for his daughter and pay cash for it. So then actually Jay Kempton is a co-founder of the Surgery Center of Oklahoma, which is a surgery center, and they've been around for over 20 years, and they don't take insurance. It's all cash pay. All of their prices are listed, and they're just set, okay? And they've been wildly successful, and people from all over the country go there. I sent a patient there. They're in Oklahoma City. I sent a patient there one time for a...
Why isn't there more of that?
There are becoming more.
Okay.
So there's something similar in Austin, Dallas, and Colorado. So they're seeing that model.
The procedure, the anesthesia.
It's all included. Yeah, because they do so much of it. They're very, very good at it, and it becomes so routine that the cost is just fixed.
What is that called?
It's called the Surgery Center of Oklahoma, and they're probably the flagship of direct pay for surgery.
There's one in Tijuana too, but I don't recommend it.
What's the name of the Austin location?
Pinnacle. Pinnacle Surgery Center. But their focus is on artists, and started off as focusing on helping musicians and artists through, it was actually a couple hand guys.
That's really interesting. That's a whole other session.
The one I know about
Music
is,
and medicine.
Texas Medical Management.
Okay, other one, thank you. Are there
I
any other?
have a...
Absolutely, go ahead.
There's a story. There's a surgery center here that was doing direct pay, and they were presenting at one of our Free Market Medical Association chapter meetings. And there was a self-insured employer there that has hundreds and hundreds of people, like over 1,000. And he's like, yeah, that's pretty interesting. I'd like a tour. So we set up a tour. The following week, I went with him to this surgery center here in San Antonio, and he's like, yeah, this place looks great. I've got 3 cases, okay? So he sent them there. He paid cash for those 3 cases. I talked to him last week about this, and he said, yeah, those patients had a great experience, and the company saved lots of money.
This is an employer.
The employer
Okay.
talking about this, he said, I think these cases, I think he had 3, 2 of them were less than $10,000.
Can I play devil's advocate for a minute there? And I think individuals who can plan accordingly and have those dollars readily available, there is an access to care in that sense that absolutely is a cost savings and absolutely a benefit to the patient. But the majority of the public isn't, because they've been conditioned to position themselves under a payer umbrella model. And so they're relying upon the coverage that they have and that they've been paying, and they still have an out-of-pocket maximum, whatever that might be. And if you have an injury, let's say your little girl, some sort of trauma, and she needs arm surgery, elbow surgery, whatever it might be, there's costs associated with that right there. How do you then envision kind of in that model being able to accommodate for those individuals? And do you have resources to help those patients?
Right, yeah, so about half of our patients are sponsored, meaning their employer is paying for their membership, and then probably about half of those employers are going to go ahead and pay for that direct pay surgery that we put in place for them, or we help them find. But for the other ones, there are brokers that work with employers that put the kind of insurance that will cover that kind of thing. But then if somebody is not sponsored, then their alternative is healthcare.gov and those kind of plans, which are really super expensive, unfortunately.
Sure.
And so healthcare.gov has been kind of designed to bring in everybody. So everybody has to pay a really high premium because we're covering everything. And so you talked about condition, and I think that's kind of what's happened over the years, over the last couple of decades, is insurance has grown to try to cover everything. But that's not the way insurance was designed. Insurance was designed to cover for catastrophic events, right? So we all need insurance, but we need to sort of restructure it.
Sure. No,
So
thank you.
everybody's predictions for 2024 is going to be a very interesting year and beyond. I do want to give folks an opportunity to come up and talk to the panelists if you would like. Thank you, all of you, for your time and your insights and your expertise. It's been really helpful. You've raised some really great points, and I think it'll help our programming in the future in terms of things that we'll explore further. And certainly you here as participants and members, if there are pieces of the healthcare ecosystem, I like that term, David, I'm sorry, Eric, that we should focus on for you, please let us know.